Hello viewers and my dear students, welcome you all in today's live class. This is Divya Pandey, nursing lecturer IGS Con, and I am here to take a live class on a very important topic from the OBG subject, that is precipitate labor, or sometimes is called as the fast labor or a rapid labor. So before moving ahead with our topic in live class, I would like to request everyone to please like, share, subscribe our YouTube channel rgcsk.edu for continuation of the live classes to enhance your knowledge level. And if you are having any suggestions or any topics other to us to take the live class, please give the suggestions in our suggestion box, comment box. So here we'll start with a topic, that is precipitate labor. We'll see about what is a precipitate labor in this, what things will be happen. So precipitate, basically first we see about the labor. Labor is a normal, natural or a physiological process resulting in the expulsion of fetus, placenta, membrane normally. Whatever the product of conception are there, they will be expelled out after some specific time, like it is 9 months, 7 days of pregnancy. So after the term pregnancy, all the things will be expelled out from the uterus of the mother or a womb of a mother in a natural process. Labor progresses gradually through the stages, and it do have the stages like and they do have the specific timing for each stages according to the multigravida mother and the multigravida mother and primigravida mother. So labor progress gradually through the stages, like first stage is the stage of cervical dilatation. So mother will start with the true labor pain and the cervix will dilate till the 6 centimeter. After that, the delivery second stage will be of expulsion stage. In this, the fetus will be delivered through the vagina, and the third stage is about the delivery of the placenta. So these are having some specific duration, but sometime the labor, those all three stages will happen very fast and in a rapid way. So it will lead to a precipitate labor, which may pose risk to both mother and baby. Sometimes the mother is not ready, sometimes the healthcare professionals are not well equipped and not ready, and the mother won't be feeling any kind of a pain, and in a sudden acute form the mother will feel pain and they will expel out the fetus. So sometimes the baby will have the injury due to falling off. So this is what about a precipitate labor. Next we'll see uh, about the precipitate labor. How labor and childbirth are the most challenging and painful phases of pregnancy. The contraction brings the pain. The mother will feel severe pain in the lower back area, in the spinal area, in the thighs area. It will be a radiating pain due to the uterine contraction. Most mother to be dread facing it and hope it get over quickly. Some of the mothers feel like this process will complete fast and delivery happen as soon as possible. Sometime the process will be very fast. Mother will be not knowing whether this is quick process will be there, especially with the primigravida mother. They don't know the process of delivery, and if they are suffering or they are the patient of precipitate labor, they won't feel like they are going to deliver because they don't know the contractions feeling. They don't know how the baby will be delivered through the vagina. So this will be happen, and also known by the term pregnancy. Sometime mother will have acute sudden pain, and with the pressure baby will be flushed out. So it can be sometime mother will feel that the process become very easy for me, within like 3 hours it is completed, so they will feel happy. Sometime mother will have the psychological problem, that they won't be capable of understanding the stages, how the baby has been delivered. Sometime because of this thing the baby got the injured, or the mother will get the some perineal injury. So it will lead to the psychological problem to the mother or the trauma to the mother. Next we are going to see about the definitions. What really a precipitate labor is. Precipitate labor, also called as a fast or a rapid labor, in the term given to the case when a woman goes into a labor and has her baby within 2 to 3 hours after the contraction is start. Basically the first stage will be of 12 hours for those who are going for primigravida mother, means those who are becoming the pregnant or delivering a baby for a first time. For them it will be of 12 hours. It is a normal, it can be exceed also, but in a multigravida mother first stage is only of 6 hours, but in precipitate labor the whole 3 stages will be of 2 to 3 hours, and the delivery will be complete, like from the true labor pain, cervical dilatation, delivery of the baby and delivery of the placenta happen within 2 to 3 hours of time. And another definition we can see, when the combined duration of the first stage of labor and all the 3 stages of labor is less than 3 hours, which has to be about 16 to 18 hours. It is less than 3 hours, that labor process is known as precipitate labor. Next, we'll see incident rate. So only around 2 in 100 women experience precipitate labor. Incident varies from 2 to 5% of the deliveries. In some cases, women don't know even they do have any high risk labors. They are suffering from this condition, or in delivery time the precipitate labor can be happen, or they are not aware whether they are in a risk factor of this condition or no, because the average the mothers will have a normal labor. Basically, at a present scenario, we will take the survey, most of the women are taking antenatal visits and information, but sometimes some myths are there in our cultural backgrounds. We'll see some myths are there. The women are not allowed to expose the pregnancy till the 5th month of time. So as we know, like as we health professional knows, the first trimester, the starting 3 months is very crucial time when all the fetus parts and everything is getting formed, and that time only we can find out the congenital anomalies in the growing fetus. So if the mother is not having any antenatal visit or any antenatal assessment like ultrasonography, urine examination or antenatal examination, grip examination, the mother won't be capable of knowing whether the mother is having any risk factor or developing conditions are there. So sometimes this scenario also can be leading to the precipitate labor, because mothers are not aware about their conditions and about the growing fetus condition. Next, further we'll see about some other incidence rate, like in cases women could experience intense cramp, that is uterine contraction, right from the start. Basically, some uterine contractions, some ranges are there. It is divided mild, moderate and severe form. But when the mother is suffering from a precipitate labor, they won't feel any kind of mild or moderate contractions. They will have the severe type of contraction. It will be of 40 to 40 and above second. Like one patient will give the uterine contraction, it will start from the 40 second, and there will be very less gap between the each contractions, and the intensity will be very high. So the uterine cervical dilatation will be very fast. Like some example we can see 2.1 incidence reports are being found in the hospital areas, about 5.4 precipitate labor cases in the recent studies had been found. So basically its ratio is very less, but we don't know when which mother will get the precipitate labor. So being a healthcare professional or a labor room worker, we need to get ready with all the things, equipment. So anytime the scenario can be happen, so we could be capable of doing the assessment and conducting the normal delivery and safe delivery for mother and for the baby as well. Further, we'll see in a next slide about etiology or a causes. What are the exact causes, or what are the combination of causes are there to lead this condition? Main causes are related to the that is about the structure and the muscle structure and the activities. How it is individually it will be different for the each mother. So to increase the uterine activity or decrease resistance of the birth canal, means the birth canal, the vaginal muscles are not that much capable, or they don't have that much resistance to hold the uterus, and so much increased uterine activity means the rapid intense uterine contractions can be lead to this condition. Strong uterine contraction we can say as the hypertonic uterus, which is very contracted, and they will push out the content into the down cavity or to the vaginal area. Reduced resistance of a soft tissue, the tissues won't be capable of holding the content of uterus or a fetus. A small fetus or preterm baby, means preterm means the before completion of 37 weeks of pregnancy, the size of the baby will be small and the space of the pelvis will be more, and the vaginal area, so easily they can be pushed out from the vagina. Then favorable positions like occipital anterior positions is there, occipital right anterior position, occipital left anterior position. So these are the favorable position when the presenting part will be the occiput, and baby can be easily leading out with the head will be delivered first, then shoulders, then body of the baby will be delivered. So it will be an easy process to get delivered through the vaginal delivery. Contractions are very close together, like there won't be any gap between the contraction, so there won't be any time for the recovery when it will come to the uterine muscles or the soft tissues, it will come, they won't get any time to get relaxed from after each contraction. So that's why they won't be capable of holding the content. Next slide we'll see about each one how with the diagram presentation and with their explanation. That first one we had seen the strong uterine contraction, that is hypertonic uterus. In this condition, uterine contractions are very powerful, like their intensity is very high and they are very frequent, very fast. There will be less gap between each and the closely spaced, short interval between each contraction. These contractions produce excessive force on the fetus and leading to the cervical dilatation and the fast delivery of the baby. So in the diagram also you can see how the uterus is like dilating, the cervical canal is dilating, dilation of cervix is there, and how the contractions are working on the uterus to pushing the content of uterine cavity into the vaginal cavity. Next point we'll see about in etiological factors. Second point is, in this only cervical dilation in the first stage of labor. It is a first stage of labor, and how the cervical dilatations are there. Next slide. Normally contraction gradually increase, but they are intense from the beginning. So the labor process very fast. Result, labor completed very quickly, and the uterus pushes the baby forcefully in a short duration of time. And the first main thing is cervical dilatation. We need to think about that, because the baby cannot be delivered until and unless the cervix is dilated till 10 centimeter. Means fully, if cervix is not dilated, baby won't be coming out. So it will be first, the contraction will be working on the uh, cervix, so it will get dilate fast due to fast, rapid and powerful contractions, and then baby can be delivered very fast. Next slide. Second is reduced resistance of the soft tissue, means cervix, vagina and perineum. The birth canal, cervix, vagina, perineum normally offers resistance to the fetal passes. They will hold the baby. In some women, especially multipara women, tissues are soft, lax and easily stretchable. Why? Because the mother already had 2-3 process of normal vaginal delivery, and muscles are already stretched, so the delivery process will be, as compared to the primary gravida mother, it will be very fast. Then dilates rapidly with a minimal force or contraction. In basically this condition or the short duration we can see with the mothers, those who are having multigravida. Multigravida means those who are going to deliver for the second or the third time. Their delivery process will be little short as compared to the mother who was going to deliver for the first time, or a primary gravida mother. Next slide we will see about the third etiological factor or the causes of precipitate labor. It is about a small fetus or preterm baby. In this we can see about the baby, one baby is of a full term or a full term infant, means after the 9 months and 7 days of delivery, when a full well matured baby will be delivered, and one baby is a preterm baby. So preterm baby, basically it will be of a small shape and size due to prematurity or low birth weight. Sometimes baby is delivered on a full term, but their weight is very less. They will come under the category of very low birth weight. Passes one more easily through the birth canal versus requires less force for descent. Descent means bearing down, means coming down. So they need very less contractions or less force to get down or to get delivered. There is a less stretching needed for the tissues, because the baby is small, they don't need much space. Easily they can be slipped down to the vagina. Labor, so as a result, labor progress quickly because the baby is encountered minimal obstruction, because there won't be any obstruction in the during the delivery. In a pelvis, they will be nicely slide down. Next slide. Sorry, for this favorable fetal position. When the fetus is an optimal position, example like occipital anterior, as we discussed previously, so head is well flexed. Small diameter of the head is presented, that is occipitodiameters. Then if this allows the small passes through the pelvis, efficient element with the birth canal, result from the labor becomes shorter and fast due to minimal mechanical difficulty. Like these all the positions will help the delivery faster. So baby will get the proper spacing to deliver out. Next is about large pelvis. Large means it will give a more space. The cavity area, especially, we need to have a thinking. Male and female pelvis are different. So the female good pelvis is like a healthy pelvis is gynecoid pelvis, and the pelvis which is having the cavity which is of 12 centimeter diameter, it will give more space to the baby to deliver very fastly and smoothly. Labor duration decreases because the baby passes easily without any resistance. There won't be any obstructions, because sometimes the co-kicks is not going back, sometimes the some points are obstructing the baby. If the baby size is big, it will also obstruct. But if we do have the large pelvis, it will give a proper space to the baby to deliver smoothly from the pelvis. Next, we'll next see about the, so here we discuss about the causes. So one easy way to remember how we can remember the precipitate labor, it occurs when there is a combination of two things. First, we had been studied in the causes also. Only two causes are there. So we have to study only two things. There will be an intense or a strong uterine contraction. And second thing is decrease resistance of the soft tissue from the cervix, vagina. Fetus will get the favorable position and some favorable position of the fetus, large pelvis. So these are in a combination, they will make the precipitate labor. So one formula to remember precipitate labor is simple, that is a rapid labor. Precipitate labor or a fast labor is equal to a strong force plus low resistance. When tissues are not capable of holding and uterus is giving a strong contraction, there will be a precipitate labor. Next. What are the risk factors? Who are in the risk? Who can get this condition? Multiparity, most important factor. Those who already, like in a previous, if we'll see our grandparents or their youngsters, we can see they do have the like 7 kids, 5 kids, 6 kids. Minimum it will be of that numbers. So as they deliver the, and basically all the deliveries used to be of normal vaginal home deliveries. So the muscle stretching will be so much every like in a year, gap. They will deliver this time after 2 to 3 years, 4 to 5 months again they will conceive. So they are also muscles. You can imagine like a rubber band, it will be stretched out how many times, and after some extent they will make that specific area they will consume and they will become stressed. So in a multiparity mother, it is very easy to get the precipitate labor. Previous history of precipitate labor, like a mother first time when she had been delivered, she already had been this condition, precipitate labor. So second time also she may have the chances of getting precipitate labor. Premature rupture of membrane, like the term is not completed but the membrane rupture is there, so we cannot hold the baby inside, the delivery has to be conducted, so that time maybe premature baby will be there. Then the induction of a labor or a balloon prostaglandins, this can also be there. Conditions can be there. Induction of labor, like we are using the medical condition, medical induction of labor with the medicines. Surgical, artificial rupture of membrane we are doing, and with the combination of both medical and surgical. So sometime in a hospitals, like the healthcare professionals are in a hurry, or sometime if we'll see in the government hospital, there will be very rush to deliver the patient. At a time 15 to 16 patients are in a queue to get delivered. So and space will be less, sometimes the staff is less, so they are in a hurry to finish their duty or to bind up with their work. So that time they will give the induction of labor with the medicines, so to enhance, sometimes their doses will be very high, so uterus will rapidly giving the powerful contractions, and delivery can be converted into precipitate labor even though patient is not having any risk factors. In a maternal factors, we can see as a tall woman, history of miscarriages. In a baby, we can see the like a small baby or small for the size baby is there, and the large pelvis are there, as we see in the causes also. So these are the basic risk factors of what we had been studying. We'll see about in the next slides. So till now we had been seeing the introduction, definitions, etiological factors, how to remember the one simple formula. Next we'll see about what a sign and symptom a woman will predict when she is going to have a precipitate labor. So when we are going to, when patient is in the first stage, we are started with the partograph maintaining. That time every 15 minutes we need to take the vital signs of the mother, FHS of the baby, and we need to see the contraction countings also we need to do whenever the patient is having pain. So we need to count whether the patient is getting mild, moderate or severe kind of contraction, and what duration, the duration between the each contraction, how much gap is there. So symptoms will be like sudden onset of a strong frequent contraction. Mother will be complaining that she is having very severe pain, and she will be have pain aside of the vaginal area and pain in the side of the rectal area. Some basically the primary gravida mother won't be aware the labor pain how it will be feeling of. So we need to explain them the pain how it will be going to be very rapid cervical dilatation, like it will take for 12 hours for a primigravida mother to cervix dilate for the 10 centimeter. But in a precipitate labor, it can be happen like in a 1 hour, it will be dilate from 3 to 5 centimeter dilatation of the cervix. Intense pain with a little warnings. Like warning signs will be very less. Like show won't be present first. It will come with a flush of amniotic fluid. Urge to bear down early. The mother will be feeling to bearing down, like to push down the content. Short or absence of latent phase, like this phase will be absence, all the phase will be completed within 3 to 4 hours, all the first stage, second stage, third stage, till the delivery of placenta it will be completed. Delivery, like, or other causes can also be there, like at home, in root of the, like if we are not aware about and we do not have any antenatal visit, we are not aware about our risk factors. Sometime while traveling, the baby can also, you maybe heard in the news and all, like one mother has been deliver a baby in a traveling in a train, in a bus, or some railway stations, in a flight. Some things will be there because patient won't be aware about, even their EDD won't be there, expected date of delivery won't be there. Sometime on those days they also get the delivery or labor due to the precipitate, or some consequent factors can be leading to the precipitate labor. Next, after silent symptom, we'll see about the diagnosis. How we need to diagnose. Diagnosis is mainly in a clinical symptoms. On the basis of clinical symptom, first, like we have to see the labor duration if it is less than 3 hours. So after the delivery, we need to prepare a note in a patient record that when delivery is being conducted, when induction of labor had been given, when the cervix dilation fully was, at what time, when the fetus was delivered, when the placenta was delivered, so any complications were arises. So we need to note down all the things. We should have a watch, or we should have some digital watches in when we are conducting the delivery in a labor room, or nearby a labor room, which can be seen. And the rapid progress of cervical dilatation, it will be very fast, like basically it will take too much of time to get cervix to dilate, but in a precipitate labor it will be very fast. Within 2 hours full dilatation will be there, which take 12 hours, so less 10 hours will be less in that. Then fetal descent, fetal will be descent throughout the labor, means it is a principle of mechanism of labor. So it will be due to uterine contraction, strong contraction, it will be come down very fast. History of onset of labor pains, like patient won't feel the pains very more, but the patient, when it will start for the labor pain, it will be very intense. It won't start from the mild or moderate, it will be start from the severe uterine contraction. Next we'll see, so till here we had been discussed about these many. Next we'll see about the complications. Here, if a mother is going through with the precipitate labor, what the complication can be arises to the mother, and it will be of both. For the maternal complications also will be there, and fetal complications also will be there. Maternal complications we'll see, like cervical, vaginal, perineal tear can be there if perineal support is not given to the mother. Second, postpartum hemorrhage, PPH, due to the uterine atony, because it is having too much of uterine contraction, and after the delivery of baby and placenta, still the uterus will be contracting so fast, so it won't be stopped, it won't let the uterus to maintain their shape and size, so that can also lead to the PPH. Then uterine rupture, it is rare, but it can be a serious condition if very severe contractions are there. The next is mother can also go to a shock, it could be of hypovolemic shock. Then some psychological trauma to the mother, as she is going through very exhausted condition, or every individual is having the different mentality or a different way of dealing with some situation. Some will be feeling good that process is completed very fast, some will be won't be feeling good that my body is not good, my baby is delivered so fast. So these can be occur to the patient. So one by one we'll see the explanation of these maternal complications. So first explanation is cervical, vaginal, perineal tear. Rapid expulsion of the fetus causes sudden stretching. Means the pressure will be on the perineum skins. So it will be a sudden, tissue do not get time to gradually dilate. The muscles or the skin will not get time to get dilated and stretch out and give the space for the baby. So that can lead to the lacerations and tears. Some laceration will be inside the cervix also can be happen. Vaginal canal can also be happen, and the outside if you will see, there are 4 degrees of laceration or perineal tears. First, second, third and fourth degree. It can be superficial, it can be till the muscle, till the bone. Skin rupture will be there, which can be after that stitching is very difficult. Like normally if we are giving a episiotomy, it is we are giving artificially episiotomy, it will be in a straight form. We can do suturing properly, but when the patient is having the perineal tears, suturing is also difficult, healing is also difficult, and it is very painful as compared to the normal episiotomy wound. So next we will see about the second maternal complication. It is PPH, postpartum hemorrhage, uterine atony. The uterus become exhausted due to excessive contraction because it was having very powerful, intense and long duration of contraction, failed to contract after the delivery. Then after exhaustion, when baby and everything is, that labor process, delivery, placenta, everything is over, then patient won't be capable of doing the contractions. That time the content of conception, sometime the clot, sometime the placenta cotyledon can be attached inside or retained inside the uterine cavity, that can lead to the heavy bleeding to the mother, that is called as PPH. Next we'll see the third complication of maternal complication. It is uterine rupture. It is rare, but it can be happen, like excessive forceful contraction increases intrauterine pressure. When the mother is having continuation of severe contraction, like the one contraction is staying for 40 or more than 60 seconds, it will be affecting the muscles of the uterus, sometime due to strong, intense and more rapid with a less gap between the contraction, that can lead to the tearing of the uterine wall, and the uterine content can be dropping into the perineal cavity, and it can become a very severe condition. We need to go for the LSCS, then we need to stitch out the uterine cavity fully. So this can be happen if we are giving, even if we are not taking care of a patient when we are giving the induction of labor, that can also lead to the uterine rupture. Next maternal complication, fourth number is shock. How shock can be happen? Because blood is also a type of a fluid, body fluid, and there will be excessive loss of body fluid, severe bleeding in a PPH. In the second point we had been seeing, the patient maybe have the PPH, postpartum hemorrhage. So during this condition, like patient will get tears, pain, trauma. So in that time also bleeding will be there due to loss of body fluids or a blood. Patient can lead to a, or patient can go to hypovolemic shock. Next, fifth will see maternal complication, that is psychological trauma. Sudden intense labor can be frightening and overwhelming, may result in anxiety, fear or post-traumatic stress, like a postpartum stress can we get, mother can get postpartum anxiety, can we get postpartum blues, they can be get. Sometimes the mother will have postpartum blues, my like they won't accept their baby, even the baby is crying, baby is hungry, they won't touch their baby, because sometime it will be very frightening how it could be happen within 3 hours. That process has to take that much time, something wrong ending. So they won't take care of their baby, agar, like some psychological traumas will be there, they won't feed their babies, they won't give any basic care to their babies. Next we'll see about the fetal complications. The next slides, what are fetal complications occurs, like first is birth asphyxia or hypoxia, less oxygen level or supply during the intrauterine life. Intracranial hemorrhage can be happen during pressurized delivery, and premature maturity complication in the fetus can be happen. Low Apgar score or injury can be happen due to this rapid process of delivery, that is precipitate labor. So here we'll see one by one about the fetal complication. But first complication is fetal asphyxia or hypoxia. Strong contraction may reduce placental blood flow, that lead to lack of oxygen. That will deficiency of oxygen will be there in the body of mother, because placenta is the one, baby is not having respiration inside, because they are artificially getting the oxygenated blood from the placenta through umbilical cord. So if the contractions are so rapid, so there sometime the blood vessels will be suppressed and flow will be less, that can lead to the birth asphyxia to the baby. And sometimes there will be a chances to getting like a stillbirth or death, baby can be delivered during this situation if the contractions are very fast. Next fetal complication, intracranial hemorrhage, like rapid passes causes sudden pressure changes on the fetal head, that can lead to the bleeding inside the brain. Means the fetal head is having the capacity to mold, they will have the sutures, like sagittal sutures can be overlap each other. So this is a natural process, they will overlap each other and they will make a shape according to the vaginal shape, and they will deliver through it. But sometime due to labor pressure, it will be descend down, and they will be overlapped. So sometimes due to more pressure and continuous more fast and intense contraction, the patient will get the bleeding inside the brain area. So that is known as intracranial hemorrhage, and those blood clots will be there inside the brain. So that can be obstruct the in a growing age, the it can be obstruct the it can create problem to the baby. Third, we'll see the complication of fetal complication. Prematurity complications, like if the baby is preterm, lungs are immature, poor temperature regulations will be there, that will lead to the multiple complication in a baby. Sometime baby growth won't be there, sometime baby won't take feed properly, they will have oxygen deficiency. So immediately we need to admit them to the NICU, and keen observation has to be done for the baby. We cannot touch baby every time because immunosuppressed baby will be there. Then they need to be kept in an ICU for a long duration of time, and basic care without like single touch babies will be there. We need to care for them like that in some cases. Next, fetal complication. Low Apgar score injury. So Apgar score is a kind of a scale which we use when the baby is delivered to assess their health status. Basically, Apgar full form is how they are appearing. According to that, we do have the numbers in a scale, then pulse rate, grimace, activity, and respiration. So according to that, we will assess the baby's condition after the delivery. Baby may have low Apgar score, physical injuries may be present because during rapid delivery of the baby, sometimes babies can be fallen down, sometimes the head injuries can be there. Basically, when the mothers are having the delivery in the squatting position, so this can be happen. Physical injuries can be sometime in while taking back out the baby, sometime the clavicle area, the shoulder area, the babies will have the injuries. Next. Next, here we'll see the management. In this first, we'll see the immediate management, what we have to do. Stay calm and prepare our emergency delivery. Like being an healthcare professional, if you are working in a labor room or you are going to be working in a labor room, you need to make your labor room every time ready to receive a patient in an emergency situation. All the emergency kits has to be there, emergency instrument has to be there, or medication has to be there. On-call duty doctor has to be get ready anytime the emergency cases can be come. So we can be prepared, whoever the staff is, that our team has to be ready for any situations. Ensure aseptic precautions, like all the sterile technique has to be maintained because we are going to work and there will be open vaginal cavity that can lead to the infection in future. So we need to follow all the aseptic techniques and precautions. Support the perineum to prevent a tear. So this is the main thing. If while delivering the baby, it will force will come down. So if we are not doing the perineum support properly, it will prevent the it won't prevent the tears. So whenever the baby is delivering through the vagina, we need to give a proper perineal support so the muscles won't get tear. Then we need, what we have to do, control rapid expulsion of fetal head. When the baby is coming down so fast, that time we need to control and manually, like manipulation has to be done to deliver a baby. Check for the cord around the neck. Like that is condition is known as nuptial cord. Okay, when the baby is having, like when our umbilical cord is more than 100 centimeters, it is a cord anomaly. 100 centimeter, the baby is surrounding or taking a movement inside the amniotic fluid. Sometime it will be around the neck and it can suppress the oxygen, and the baby will have the asphyxia. The baby will won't be having the proper circulation. This condition can be happen. So this was about the immediate management. Next we'll see about after delivery, like the patient delivered the baby after. So what we have to do, mother still can have the PPH in their postpartum time. So first of all, what we have to do, active management of third stage of labor. What is third stage of labor? It is a delivery of a placenta. So that how we are going to deliver, what medicines we are going to give, and then uterine massage, how we are going to do, how we are going to suture the things, so we can prevent the postpartum hemorrhage. Examine for and after the delivery. Before doing the suturing, if we are giving the episiotomy, then before giving the suturing, what we have to do, we need to see for if any perineal tears are there. We should not tell that tear is there. We need to see the exact place where the perineal tear is there. Any retained placenta or retained product of conception is there, because they can lead to the PPH. Then monitor. We need to have a keen observation every 15-minute vital signs, and uterine bleeding we have to see exactly from which place the bleeding is coming. Sometime injury to the bladder can also happen, sometime to the rectal area also can be happen, sometimes cervix can be injured, the vaginal canal can be injured. So we need to find out what the exact place where the patient is having bleeding. It is about the after delivery, how we have to do the management. Next, what being a nurse, what management you have to do, like you need to first of all provide emotional support to the mother, especially because the mother is going with a very exhausted stage. They won't understand what is happening. Even the multigravida mother is that they will also won't be capable of handling this situation. Prepare emergency delivery kit. The kit has to be every time ready. Monitor fetal heart rate, and when the precipitate labor is there, even the patient is on the labor cot, that time also we need to observe the fetal heart rate, whether it is going low, high, or any situations are there, so we can tackle it out. Assist in the safe delivery, like always you should instruct your patients or your nearbys to always have the antenatal assessment, intranatal assessment, and should motivate all for the institutional delivery. Educate the other about the future risk, like if you are had been faced this situation, or whoever working in the labor room, they should be aware this condition can be come to any point. Any patient is normal only and they will sudden they can start with this intense powerful pain, so they can lead to the precipitate labor. So we should be make aware of ourselves as well, our others also, those who are going to deal with this kind of a patient. Next we'll see prevention, how we can prevent. Like we cannot predict, like some causes are there, so those causes we can have a management, we can educate the patient, we can suggest them to early hospitalization, like early hospitalization for high risk women. Those women are in a high risk conditions for labor, we need to, like they should have a proper visit, they should be get admitted at 10 days 5 days before the EDD dates. Identify women with the previous precipitate labor, like they should have their documentation, we should collect the history of the patient, like marital history, menstrual history has to be collected for the each patient. That's why the history collection is one of the most important thing when we are going to diagnose a patient or when we are going to doing a care for a patient. Close monitoring in the late pregnancy, like in a PPH time also, or in a mothers, those who are more than 30 or 35 years, if they are getting pregnant for the first time, it can be happen a precipitate labor, so we need to educate them as well, and the preparedness of the staff and healthcare professional has to be there on these situations. So these are some points on the prevention, how we can tackle the situations. Next is about conclusion. So till here we had been discussed about the introduction, definition, what is precipitate labor, the etiological factor and causes we had been seen. Then we had been seen about the risk factor, sign and symptom. Then we seen the complication both for the maternal side and the fetal side. We are seeing the preventions, what we can do, the management, active management, immediate management, nursing management. And here we came with the conclusion of this topic on today's live class. Precipitate labor is not a rare and it associated mainly with the maternal trauma rather than the severe neonatal complications. In precipitate labor, baby is a less responsible if will see. It will be because of the maternal body, uterine muscles and the other muscles, soft tissue muscles, those who are not capable of holding the babies. Precipitate labor is a rapid and a potential hazardous obstacle condition. Early recognition, preparedness, and prompt management are essential. Like proper antenatal care has to be done, dieting, exercising, suggestions, investigations has to be done in the first trimester, like in first to third month, all the investigation has to be done. In the starting 3 months, we will be capable of knowing whether the patient is developing any high risk complication, whether they are coming in the category of high risk or any situations can be arise like this. So it is all about precipitate labor. Thank you for listening, joining and watching our YouTube channel rgcsk.edu. Hope you like this class and it is useful and understandable for you all. Thank you. Have a good day and keep in touch with our rgcsk.edu. Thank you.